that's in our room here with us live to find their seat. Please feel free to grab lunch and beverages on the back. And I know we have many people joining us at home and at work, at their desk, or on their phone, and I just want to say thank you to everybody who is here with us, both in spirit and in person. What a joy it is to look out and actually see faces and people gathering in the name of such a worthy and important cause in Polk County. My name is Alice Nuttall, and I am the Associate Vice President of Behavioral Health Services for Lakeland Regional Health. I also serve on the Polk Vision Operating Board, and I am the co-chair of the Polk County Behavioral Health Team. I would like to welcome you all to our Mind Matters Lunch and Learn, where we will focus on the topic of behavioral health in Polk County. Thank you for taking time to join us today. This event is brought to you and sponsored by the Leadership Polk Alumni Association and the Polk Vision Behavioral Health Team. Now, before we begin, I would like to alert you all that those of you viewing online, you will have an opportunity to text your questions when we get to the Q&A period towards the end of our panel discussion. You can text your questions to the number 863-888-2911. And for those of you that are in our room with us, you can see that there are some cards around on the tables to remind you of that number, so you also can participate in the questions and answering period. I would like to say a special thank you to the Polk Vision Board of Directors for their leadership and to our host sponsor, the City of Winter Haven. How wonderful and beautiful this facility and venue is today that has brought us together. I would also like to thank PGTV for live streaming today's event. It truly helps bring more people to this crucial conversation of behavioral health. A quick housekeeping item to all the panelists before we begin. These are hot mics, so anything you say, it will be heard. But please remember to talk directly into your mic the way I am here, because this is what makes the audio really good quality for those viewers at home or at their desktop. Lastly, this event is being recorded by PGTV, and so we will have access to it at a later time. So I want to give you a quick, just brief intro on myself a little bit further. I again said that my name was Alice Nuttall, and I am a daughter of Polk County. I was born and raised here. I was actually born at Lakeland Regional Health. I am a product of the Polk County Public Schools, go Dreadnoughts, and I moved away to Nashville, Tennessee to attend Vanderbilt University, where I received a degree in neuroscience psychology. I've worked in the field of mental health for over 2 decades, and along that journey, I became a nurse as well, and I did a lot of work in the critical care nurse residency program at Vanderbilt University. My heart and my passion has always lied with caring for families, patients, and communities around the topic of crisis, when individuals need help but may not always know they need that help or how to get it. 3.5 years ago, I came home, and I have never been more excited and joyful to work with such a vibrant, amazing community. And joining Lakeland Regional Health was really at a pivotal time where we began growing and expanding behavioral health services. I also, very short period of time after I arrived, found Polk Vision, and these are my people. It is wonderful to be a part of the Polk County community when we tackle such hard and difficult problems. Polk Vision was founded in 2003 as a public-private partnership. Polk Vision is a nonprofit strategic planning organization providing collective impact services across Polk County. The organization supplies central coordination to the work of hundreds of cross-sector volunteers focused on developing strategic system solutions to the county's most pressing challenges. Polk Vision identifies community priorities and raises awareness on topics such as homelessness, food insecurity, literacy, public health concerns, behavioral health. They provide education, they build collaborative partnerships, and they promote mutual accountability. Now, in the fall of 2019, Polk Vision was urged by representatives of the Citizens Healthcare Oversight Committee and the Florida Department of Health to explore the topic of behavioral and mental health in Polk County. This request was based upon early research findings of the Polk County Community Health Needs Assessment from April 2020. And I will also say that all of the community health needs assessment across multiple organizations here in this region, all of us find the most pressing, or one of the most pressing health concerns is behavioral health, time and time again. This includes concerns and conditions of mental health and substance abuse. It is a leading health priority for all of us in this room. Even if behavioral health isn't something that you work and talk about on a daily basis, it is a part of who you are, and it is a reason why your community needs you to be here and present in helping us solve this situation. With funding supplied by the Citizens Health Site Overcommittee, together with 4 major healthcare providers, Advent Health, Baycare, Central Florida Healthcare, and Lakeland Regional, Polk Vision contracted a qualified consultant to perform a behavioral health needs assessment. It was launched in July 2020 during the pandemic, and that research spanned 11 months. And I'd like to bring your attention to Holly Vida in the back. She's my beloved co-chair for the Behavioral Health Exploratory Group on Polk Vision. Some of our other members are here today. I see Gwinnell Brandt from the Sheriff's Office. I see Joy Johnson from the county. There are so many other people that have been integral to this work, and we are so very proud of the results. One of the reasons is it was in the heart of the pandemic when many of us couldn't gather and meet in person. But what spanned that 11 months were countless one-on-one interviews, surveys, focus groups, roundtables, talking with individuals even like inmates and foster care families. We gathered an incredibly rich and diverse data set of narratives about people in our communities. And from that, we developed a sequential intercept map, which really is a fancy term for where are the gaps. There is so much good work that's being done by a lot of the agencies that are represented here today in the space of mental health. And mental health services have existed in our county for generations, but it hasn't met the need. We still have individuals in pockets of our community that don't yet have access to services. And so this study allowed us to not just map out where those gaps were, where those intercepts where patients were missing and individuals and families needed more help, but it also allowed us to take the next step to figure out what are some of the ideas and priorities that the community sees as important. What are going to be our next steps? Well, one of our next steps is what we're doing today. It's conversations around behavioral health. It's learning as much as you can, increasing more the words and the ways that you are going to be able to be knowledgeable about this and speak about it with others in your community. We have a purpose today, and raising awareness and having a conversation around behavioral health is at the forefront. So at this time, we will have the panelists introduce themselves. And let's start with our beloved constitutional sheriff, Grady Judd. Now, not much introduction is needed, as we all know him so very well. But Sheriff Judd, why don't you share with us today what brought your personal attention to this topic of behavioral health in Polk County?
Thank you, Alice, and thank you for the work that you're doing. And I really appreciate Polk Vision because they have brought us all together for this very important task. Now, I've worked in law enforcement my entire adult life, so what I give you today is not necessarily empirical evidence as much as it is observations from not only the deputy level, but as I went through the ranks and am now sheriff. And here's what I've found. I've seen a degradation of services to those in need of mental health and behavioral health services over my career. And why do I say that? When I first began my career back in the day, when we had someone that needed help, we Baycare acted them. We also had a county hospital that we could take folks to that needed help. And ultimately, we had a state hospital, a behavioral health hospital, G. Pierce Woods, it's just south of us. We saw all that go away, and the philosophy was, well, medicine is better now. All they have to do is take their medicine and everything will be all right. So we saw our hospitals go away. The only problem is the medicine wasn't there. And for the ones that was, once they got to feeling better, they quit taking it, and that's, we all know about decompensation on their part. But as a result, I have cared immensely about those that were significantly struggling with mental health and behavioral health issues. In fact, long before it was cool, I ask that all of our deputies, both in detention and law enforcement, be crisis intervention trained, as well as all of our communications teams, our 911 operators, as you know. Now, some said then, and a few say now, well, you really don't need everybody trained, you know, just the ones that have the greatest passion. Well, in my shop, they all better have the greatest passion, okay? Because our job is to help them quickly and to get them services and to recognize that if we can get there, de-escalate, turn them over, then they get help. The problem is, once we've provided the front-end service and got them Baycare acted, the wraparound service or the follow-up has been the weak spot in all of this, and we need to change that. Well, you add to the fact that I had a natural passion for helping those that are less fortunate and those that had behavioral health issues. And then I was able to be appointed to the Marjorie Stoneman Douglas Commission that investigated and still is investigating that horrible event that occurred at Parkland whenever all those children and teachers were shot and many of them killed. What we learned as subsequent to that through all the commission meetings just refuel my fire about how we need to help those. That young man, and I don't like to use his name, that shot up and killed all those beautiful children and students and staff that day, had many direct, if you will, referrals from mental health services. But let's remember this from my perspective today, silos, lots of silos. Oh, we can't talk about that. What we found is one mental health group wasn't talking to another mental health group, wasn't talking to another mental health group that had all dealt with this kid. They in turn weren't talking to the schools. The schools certainly weren't talking to the law enforcement officers because we put up all these firewalls to provide or protect people's privacy. Well, ladies and gentlemen, what you did with the advent of all of these firewalls to protect privacy was you guaranteed failure of the system, because all of us want to care for them. I mean, let's face it, why wouldn't you trust law enforcement? We deal with the most sensitive matters in this county. We deal with matters of national security, state security, local security. We've got lots of confidential information we're trusted with that's far more delicate than helping someone in a state of mental health crisis. But if we can break down the silos and figure out that we all take all these resources that we do have and work together, and then we figure out the wraparound services. I've heard about co-responder models and let behavioral health respond instead of law enforcement. But as I close down my introduction, we've got the front end figured out. When people call us, most times the ones that we deal with are in a significant crisis, and most of the time, not all of the time, but a lot of the time, the person that we deal with, a mental health counselor can't deal with by themselves anyway. But once we safely get them to resources, our goal is to provide them the resources so they don't have to come back around. And that's where I'll end today with the program that we're working with Kirk Fasshower in Peace River. And before I go any further, I can't say enough about Kirk. He's been with us from the very beginning. He's gone above and beyond to help us out as we want to help and are helping the community. So are we doing remarkable work? I think so. Are we doing enough? Absolutely not. Is there long-term services that these folks need? Not to the extent that they need them and the way they need them. And I think we can resolve all of that once we break down the silos and work together.
Thank you so much.
Agreed. Hello, everybody. My name is Kirk Fasshower. I'm the Director of Crisis Response Services out at Peace River Center. And as Sheriff Judd mentioned, we've been working very closely with law enforcement for many years, before it was a hot and trendy thing even. We have a history going back to 2001 where we have partnered on many levels. And we've got a mobile response team. Before that was hot and trendy. We've had it in this community for a long period of time. And we've got some really good, innovative ideas and services in this community, but I agree with Sheriff Judd, it's just not enough. We need to do more. And we need to be able to communicate with one another. That is a big factor in helping each other, because even the research bears out that working together as a community, as a village, if you will, it does take a village to help people out when they're struggling. And with this population in particular, those with serious mental illness or in any type of mental health crisis, we tend to push away and back off. And so we've got a lot of elements here where we're starting to, let's pull them closer. Because when it comes to mental health kinds of issues, and when we do push them away, we don't push people away who have cancer. We don't push people away who have heart disease. And yet we've got wonderful labels for those folks: survivors, fighters, strong, heroes. Quite frankly, all those labels could be used for anybody who's struggling with mental illness or mental health kinds of issues, because those are serious struggles and very, very much so deep-seated, quiet, private struggles. And unfortunately, when they come to the level where they have to be seen by deputies and in the community, it's very hostile, and it's at a point where it's gone a little too far at that point. One of the innovative things that I've been proud to be part of is the CIT, Crisis Intervention Team Training. That I was part of the task force to help bring it here, and have been in the early stages of Sheriff Judd's placement in office with regard to CIT. And at first I was not a proponent for everybody getting trained, but then I do see the value in it, especially in our kind of a community where we're so large. And so CIT has grown over the years itself to come to be what it is today. So we're actually in the middle of a CIT school right now. I'm taking a break from instructing a lot of trainees and cadets at this moment to be here with you all today. And we'll talk more about the crisis response team and where we're going with that, and the continuing and growing partnership we have with the Sheriff's Department and other law enforcement in our community. But I'm going to turn over the introduction to Dr. Winny.
Thank you. I am Dr. George C. Winny. I am the Regional Medical Director for the East Region for the Baycare system. I came here 17 years back, and I'm working at CBH, and I'm a child psychiatrist. I'm also the medical director. Now I am the Regional Medical Director. And I'm a clinical assistant professor with FSU, because we have a residency program going on with Winter Haven, and I am also the site director. I have can you hear me? Can you hear me better?
Yes.
I have a passion. When I hear a voiceless cry of a broken heart, I stop everything. Even in the party, even in the celebration, I'm not interested in it. I'm only interested in the voiceless cry of a broken heart. In that passion, the people will open their heart, tell me everything. I became the part over the 17 years of this county. I became the voice of the voiceless and the broken heart and the kids who open up things to me. When a child is coming to me, why should I be alive? And I have to answer him, what is the purpose of their life? There is something really wrong here. Because before I come here, I was trained in India as a psychiatrist at WHO Center in Research and Training of Southeast Asia. I used to work for ICD-10 at that time in India in 1984. Then I came here and was trained at Columbia University, and I did my fellowship in child psychiatry at Bellevue, and I worked at the New York City jail at Rikers Island. I was in charge of 300 criminals for mental health. Then I moved to Illinois. Then I was a medical director there and taught at Loyola Medical School for 14 years before I come here. When I came here, people were asking, did you take a wrong turn? No. This is my town. This is my city. This is my place. Your humiliation is mine. And your weakness is mine. I am there for you. So I am here for 17 years. And I become the part of the child and the teenagers and this community. Because there is a child in me which can communicate with the child in you. I have a teenager in me which can communicate with the teenager in you. There is an adult in me which I can communicate with the adult in you. There is an administrator in me. I can show very powerful language which you have difficulty to understand, which I do know. But I meet them where they are. They are mine. So when I come here, I talk a lot. Now it is in my silence. Others talk. I listen. I want to learn from you. I am Dr. Winny. I represent Baycare system and also Winter Haven Hospital, the outpatient, inpatient, and the consultation. And when I come here, the one sentence really got my attention, because CBH, that is the outpatient division of the Winter Haven, was established in 1967, which was created as the first community mental health center in the United States, and developed with the federal funding. And we heard the call of the then President John F. Kennedy. And I am honored to sit in that seat and to say, I represent CBH, I represent Winter Haven, I represent Baycare system, but I am yours. Thank you.
Okay, hello. My name is Nicole Sweat. I'm the Behavioral Health Program Manager at Lakeland Regional Medical Center. I've been in the field for 20 years and actually in the same department. I've served in several different roles, from a mental health tech, worked with the insurance division, did social work supervisor, and a manager. And now my new role is the Behavioral Health Program Manager, which I'm very excited about. Obviously, I haven't worked anywhere else in the hospital, so I'm very passionate about behavioral health. I feel that it's such a need in the community, and it's just growing. It's a very exciting time now for Lakeland Regional with our new building and our expansion of our current programs and new ones that we're going to be adding for everybody in the community. Currently, we serve a lot of patients that are in crisis. We're a very busy hospital. We have a great team that we work with together to be able to serve all those patients. And like the others had said, it is a challenge sometimes to get them to the next level of care, but we're working with all the partners that we can. Our teams work with Tri-County, Peace River, Baycare every day to try to get those patients to where they need to be so they can continue on their journey and stay healthy. Part of my team is the mental health intake crisis counselors that meet the patient when they first come into the hospital. Then they also, are seen by a social worker in the behavioral health field, and they do, education to the families and discharge planning. Also, my team consists of recreational therapists and group therapists that work with the patients while they're in the hospital to continue to provide them care while they're in the hospital. I'm just very excited to be here and work well with everybody here, and want to continue to partner and break those barriers down so we can continue to get patients the care they need all the time. Thank you.
Hi, I'm Nelda Jackson. I am a licensed mental health therapist, and I'm also a master's level certified addictions professional. I'm also internationally certified alcohol and drug counselor. I have worked with Tri-County for 27 years. I've been in the field for 40 years, if that tells you anything. I've seen a lot of changes, and Sheriff Judd talked about the silos, and I've seen so many changes from where we would not work with each other to where now we're reaching out. I really appreciate Polk Vision for bringing this together so that we can talk about it and we can continue to communicate about what is needed and where we need to go. I currently am the Administrative Director of Residential Services for Tri-County. I oversee 5 residential facilities. Actually, there's 6 if I include transitional living, where we bring mothers and children together. I also oversee the detox residential unit. There we have housed care coordination, where we reach out and try to provide extra services, wraparound services for that high-need, high-utilizer population. We have special health care education that is brought to all of our residential facilities, where it could range anywhere from teaching the individuals when COVID first broke out to how the substance is affecting your body. We also receive Marchman Acts at the detox facility. There's a lot that goes on in that building. Currently, I'm just passionate about helping individuals who suffer with substance abuse and mental health issues. Have been for years, have personal experience with it, so I can really relate. I started as just a direct care staff, human services tech. It wasn't long before I had moved to a counselor position. Then, of course, they moved me to clinical coordinator, and I started supervising a program, and ended up where I am because I could see a need of how we have to have a voice. We have to speak up. We have to provide. And residential treatment is expensive. We all know that. So we really have to continue talking about it, because we have those individuals who literally cannot make it through outpatient services. So we need to continue talking about that. Currently, my passion is with the pregnant and postpartum population. I'm working on a grant through SAMHSA. Hopefully we get it. It's a 5-year grant. And I'm now reaching out to different partners in the community to start the conversation and say, how can we work together on this to provide these women what they need, because it's so vital right now. So that's who I am. Thank you for inviting me.
Thank you so much for all of our panelists today. Don't we have a tremendous group of individuals here today really committed to this work? Now, based off my knowledge of the topics and of the studies surrounding behavioral health, I've developed several questions to start today's conversation. But don't forget, you're also a very, very important part of today's conversation. We want to, again, encourage you to text questions throughout as they come to your mind to that number I provided earlier, 863-888-2911. And Holly Vida from the back will bring me those questions. Now, I also want to remind for our panelists, even though the sound may be okay here in the room, speak directly into the mic the way I am here, so you can move it up when I direct a question your way, just so our viewers at home and on their smartphone can hear your valuable insights. So, Sheriff Grady Judd, we surveyed almost right over 300 inmates, actually, in the study that we provided and performed through Polk Vision. Tell us a little bit more about the survey of jail inmates that occurred here through the hired consultants, and what were the lessons and things that you and your team really took away from that?
Certainly, Alice. And I want to tell you that because of Polk Vision's energy, we wanted to be on the ground floor of this. And I asked Gwinnell Brandt,
Yes.
who is my Director of Professional Compliance, to take on another job. So I thought, well, this is going to be something short-term, and the more we got into it and the more energy that Gwinnell saw from this team, she said, hey, this is going to be full-time. And she's volunteered to change jobs and now be my Director of Behavioral Health Services at the jail and for the law enforcement side. So when this opportunity came, we found out that they weren't surveying the jail. So we asked why these experts that we'd hired were not asking to survey in the jail. And the answer was, well, nobody's ever let us do this before. They had, in fact, inquired around the nation, and whoever was in charge of the various jails refused. And I go, well, wait a minute. We have like a captive audience here. And the people that we deal with, many of them in our county jail, have behavioral health needs. We had a special needs unit, and we've had one of those for years and years and years. We all know that what it is, it's a mental health unit. So I changed the name to a mental health unit long before all this was cool. We repainted all the walls, and we try to treat people appropriately. But here's what we found through the survey, and this is why the survey was so very important. We found the top 3 reasons individuals didn't get help before they were in jail was they couldn't afford it was number 1 at over almost 41% of the people. The second was they didn't know where to get help. And at 38, almost 39%, and then at almost 33%, they didn't have a way to get there. So before they came to jail, they were receiving no services. Now we think of jail as, oh my gosh, we're in jail. But we did at least have the opportunity to provide an environment and offer them to see a doctor and to receive psychotropic medications for their mental health issues while they are in jail. So at the end of the day, we were making what little progress we could, and certainly this was back in the day, and we noticed as soon as they got out, the medicine that we had provided for them, they no longer could afford, or it was no longer available, and they decomped, and we would see them back in our services. Well, along the way, Dr. McMicken, and for those of you who knew Tom McMicken, he's passed away. He was my physician for quite a bit of my life, and he was a dear friend of mine. And we were sitting at Rotary one day, and he says, Grady, I've got a vision. And we'll call it a Helping Hands program. And he was instrumental in the half-cent sales tax money. And he says, what do you think about us plugging this in at the jail? And I said, I'm in. I'm all in. Here's what we've seen. We now have connections. We've been see connections from the time they're incarcerated. We have hooked up Horizon in this process, not only with the Sheriff's Office, but with Polk County Health and Human Services and Fire Rescue. Central Florida Behavioral Health Network is involved. Tri-County is involved. Winter Haven Hospital Center for Behavioral Health, LRH, and Peace River. But the program creates medications, or ensures that they have medications, therapy, peer support, advocacy, and mentorship. And this Helping Hands program has not been in place long, but it's one reason I'm pretty excited. I think about Dr. McMicken has passed away, but his vision is still doctoring people today. That's the kind of man and the kind of physician he was. To date, we've had 135 inmates who participated in the group meetings. 79 of those inmates were served once they were released, and there's been a 71% decrease in jail days. Did you hear what I said?
Yeah.
That is huge. So what does that tell you? It tells you we're helping people and they're not coming back. So, and that's important to me. So we plan to expand the program to some inmates of greatest need. Now, some of those of greatest need have been heretofore so violent that we said, wait, don't start with them. Let's start, if you will, with the cases that are most likely to be successful, the easiest, until we learn our way. So we're only in the infancy of this. But just think, if we can keep people out of jail, on their medication, not committing crimes, which means there's not new victims, then it's a win all the way around. So we're excited, and it comes down to what I'm going to say every time I get a chance, because we've started breaking down silos, but there's lots of work to do still.
I'm so glad you mentioned the Helping Hands program, because I really feel like it's one of the crown jewels of the behavioral health teams, and it's because all of us agencies are working together as one. We're all on a shared release. It's something that's really innovative, that's impacting our community and our citizens. Now, there are various law enforcement response models in place around the country, and Sheriff Judd, can you tell us what your agency specifically has implemented around law enforcement response models?
Sure. Our visioning here is that if we spend our precious resources on creating another front-end model, and that's what I've seen around the nation, then where do we have any money left for wraparound services? I suggest to you no. So what I want to do is I want to have the energy of the resources already in place dealing with what I call the crisis cases. And it is a crisis case when they call us as opposed to walk in for services. Let us train, and if we need additional training, that's fine, but let us deal with it on the front end so we're not taking these precious resources and creating more front end services. Then when we are able to take these folks that need services and put them in via a Baycare Act, then turn them over and say, here they are. We've identified the ones that have significant issues, and let's take that precious money and follow them and ensure that they have their medication and their counseling. We know we'll see a reduction. So once again, Kirk Fasshower has worked with us, and in what I instituted, not as a result of policy or law, but my deputies, anytime they Baycare Act someone, they have to follow up with that person, independent of any more demand for service, after they get out of the hospital and say, hey, do you have your medication? Are you taking your medication? Do you have your counseling? Are you working? So we have been doing this on our own. So Peace River said, hey, we'll take that over. So we beta tested it in one of our districts, in our Northwest district. 23% decrease in multiple Baycare Acts when we've worked with Peace River. And you see, when we were able to hand them off rather than us doing the follow-up, and then calling Peace River or calling a mental health group and saying, look, we Baycare Acted them, they let them out of the hospital, but the Baycare Act, as you know, is only good for a max of 72 hours, but they're not getting any services or medicine. Now, Peace River, we're handing them off, and Peace River has shown a remarkable reduction in multiple Baycare Acts in one district. Now you extrapolate that over all 5 of our districts, soon to be 6, and you see that the chances are remarkable, and the people are responding to services when it's available to them. So as a result of Peace River taking a chance on us, and we were doing all this before it was cool, before it made the news, because of our heart in this county for helping those others. So I don't want to get over in Kirk's area, the community mobile support team is just phenomenal. So we want to expand what we're doing, and then we'll tweak it and bring the experts in. So we'll say, okay, we're kind of like the firefighters. We'll run there and put the fire out and calm it down. But then we need somebody to rebuild it. We're not in the construction business. We can't rebuild the house. We can just calm the fire down, and then we've got to turn it over to the real experts to do the follow-up. I think we get economies of scale. I believe we have a force multiplier because we've got front-end services already paid for, not taken away from mental health. And then we take the precious few resources that we can cobble together until we can get more resources and show this really works. It's been successful.
Well, I just want to take a personal moment and tell you thank you, Sheriff Judd, for, as a personal person who is dedicated to this profession and this field, as someone who lives in Polk County, you have been such an advocate and voice for us here locally, within your own agency, but also on the state and national stage. And I feel like all of us are going to be trailblazers really, truly, because of your passion and support. So thank you so much for that.
Thank you for the partnerships.
Absolutely. Now, Kirk, thank you so much for being here, and I can't wait to kind of hear as you share with us a little bit further. And some data I wanted to share with you briefly from our study before we hear from Kirk. By the way, we can make this study available to all of you. It's wonderful poolside reading for your spring break plans. But since 2011, Polk County has had a higher rate of involuntary examinations, or Baycare Acts as we call them, among residents than across the entire state. So the average population, it's 1,007 per 100,000, and in Polk County, it's over 1,200 per 100,000. We also see from the data of this study that about 24% of Baycare Act involuntary commitments today are children under the age of 18. So think about that. Almost a quarter of the Baycare Acts that we're seeing today are kids. They are our kids and our kids collectively. So we know, Kirk, that you and your team have just been doing tremendous work in crisis services, and you have been expanding and trying some innovative models. Please share with us, over the last 2 years, what you have seen and where you think your team is going.
Sure. The crisis response team has been around since 2001, and it's been, as Sheriff Judd said, one of those front-end kind of models where we're trying to get out there and prevent and divert where we can get people connected into services. And back then, it was kind of, try to find any information on trying to create this team was impossible. Now, we're talking about it in a great deal. So we've had some innovative front-end kinds of stuff, but now, looking at what's happening in our communities across the nation, just being ahead of the curve here in this area with regard to, hey, what can we do, working with law enforcement to, you're going to do the Baycare Act. Now, what about that follow-up? The part of that innovation is being involved in the National Crisis Intervention Team Foundation. That's the one that trains officers. They get a 40-hour block of training on how to work with individuals with mental illness and how to de-escalate situations and do some follow-up. That's part of the program model that comes with that. But over the years, what we have found is that, okay, it's the intent was good to have somebody come in uniform in a non-crisis situation so that it kind of softens the blow in a crisis that, as opposed to escalating it. Well, over the past years, unfortunately, the climate it raises anxieties when you see somebody in uniform, unfortunately. And none of the men and women who get involved in law enforcement ever want that. They're there to be helpful. And so we're able to, now, as we innovate with this program, we actually tried this out in 2007. We had a small grant that we had for about 3 years, and again, with Sheriff Judd's partnership, we were able to work in Central District office at the time, and we did exactly that. We did the follow-ups to the Baycare Acts that law enforcement initiated, taking some of the burden off of them with the CIT model and just adding, let's put a mental health person doing that follow-up, following up with the deputy, hey, I'm going to go out and see Kirk, I'm not really sure about him, what do you think? And the deputy can say, yeah, you're good to go on your own, or I think we might want to go together because Kirk's a little violent sometimes. So again, it created that partnership. Well, unfortunately, at that time, the funding kind of dried up, and ever since then, we've been trying to figure out a way, how do we get this back? How do we get this back? And the last couple of years, we've been able to find that money and started really building on that. Instead of just one district, though, covering the entire county, we're now looking to place crisis counselors in each of the district offices on site. So they're there building those partnerships with the deputies at those district offices. And what happens is, the deputies are doing their work, they're doing a really good job, and then they go, oh, hey, you would have been good to come out on me on that particular call. Here's their Baycare app, let's do a follow-up. We'll do a follow-up on that. So it creates a much more richer approach to working with individuals post-Baycare Act. So we're doing some of that follow-up care with the mental health counselor going out there and really trying to break down some of the barriers in our own system, because we all know our system is, we got some work to do on our own system. It's a struggle for us trying to get in there, get services. Here's somebody with additional issues trying to struggle to get in there. So now we've got folks guiding them through that process. Because we go in, we're not doing a one and done kind of deal. We're doing multiple follow-ups with individuals until they're linked with either Lakeland Regional, Tri-County, Winter Haven. We're making sure they're getting connected to those services by following up and saying, oh, you've got this appointment tomorrow at 10 o'clock? I'll call you at 12 o'clock to make sure you made it okay. Tell me how it went. And if they haven't been able to, we start to look at, okay, what happened? Because people a crisis happens, everything's immediate, the crisis subsides, and it's, I'll get to it whenever. No, we're there to kind of nudge the reminder, look, we don't want you to go into crisis again. And we've been able to turn people away from another Baycare Act. You know, that first one happens, like, we don't want to see, nobody wants to see that happen for that person again. Let's work with you to help get connected to those services. So yeah, in that one district we saw that tremendous 25% non-repeats. We're starting to see it replicate in other districts. We have at least one counselor in every district right now. The goal is to get 2. We've got 2 in Southwest at the moment. We're working on getting 2 in the Northeast, Central, Northwest, and Southeast.
That is truly incredible. And thank you so much, Kirk, for you and all the work of your team. I know that there is just so many calls that come in on a daily basis, and knowing where to start when you get that call is such an important skill, and staying calm, which, again, so thank you so much for doing that. Now,
Alice, can I add one thing real quick?
Yes, please.
You know, we talk about, we've got more calls for mental health here,
Yes.
Baycare Acts here. Is that because we have more of a problem, or we're more in tune to helping people? You see, if you don't help, if they can't get resources, they quit calling.
That's true.
So I'm always cautious, because people used to say, well, do you have so many more sex predators, you arrest them? No, we go out and find them where they are, not only across the city or county, but if we quit arresting sex predators, does that mean we don't have sex predators, or we're not doing our job? The same thing here, when these folks heretofore have not received services, and all of a sudden, Peace River's offering services, and we're not turning our back, and we go to somebody's house and they go say, well, I'm thinking about committing suicide. Well, that's magic words. You got to go see a doctor, because we're not driving away and letting you not only contemplate, but maybe commit suicide. So I'm always suspicious, do we have a larger problem here, or are people reporting because they get services?
It's a good point, and definitely something to consider. Speaking of suicide and people kind of really knowing where to reach out, or that concept of no wrong door, there's a lot of talk, Kirk, around this new suicide hotline, which will be the 988 number. Can you share with us a little bit about the 988 hotline and how Peace River is going to really help bring that to the Polk County area?
Sure. So currently we do have a crisis line. It's 519-3744. I'll repeat it, 519-3744. Feel free to give out that phone number to anybody you feel may be in any type of emotional distress. You know, quite frankly, I don't care. Write it on the bathroom wall for a good time call. I mean, somebody's going to answer that phone. You know, and that's there. Now, with 988 in particular, there is a national suicide hotline, and they have been getting overwhelmed. And they have a network of agency providers in local communities, but that network is being taxed. So what has ended up happening is, rather than have this rather lengthy 7-digit phone number for people to remember to try and call, they have now, the FCC has now allowed for 988 to be that 3-digit phone number for anybody in any type of emotional distress or contemplating suicide to call that number, and they'll get connected to a crisis counseling call center, if you will. So what we're doing here locally with Peace River Center is we're shoring up our crisis line number and our crisis line services to be much more of that call center here locally. At this point, the application is in the works. There are a lot of applications that's happening, but come July, folks will be able to dial 988 and get connected to a crisis suicide prevention hotline. The trick there, and it gets a little more complicated when we start getting into networks like this, is the number may go to a place in New York, and then if that line is busy, it's going to bounce over to Nebraska. And then if that line is busy, it may go into Hawaii. And if that's busy, it's going to bounce over to Texas. We have some numbers. It's close to about 2,000 calls that get bounced around from our community into other areas. So I'm always a proponent of, hey, let's keep things at home here because we know our folks, we know our resources. And so we've been pushing hard to really build our muscles as far as a call center goes to handle these types of calls. Nationally, they're talking about huge increases in calls. I'm a bit cautious in that arena. I don't know that they're going to be 300% increase like they say. It's not going to be we flipped the switch and magically everyone's going to start dialing 988. They're still going to dial their local community numbers. There will be those local resources over time. And even with 911, way back when that first was created, it took time for it to build to where it is at now. Because most people when they think of a crisis, they dial 911. And they get those resources. And in our community, as in many other communities, they're going to send out law enforcement to go check on somebody. And then there'll be some additional follow-ups, which is a good mechanism to make sure people are safe. And then we start tapping them into some resources. But there are many who call a suicide hotline to talk about their suicidality and talk with a counselor. And many of those counselors, we have a wide array of paraprofessionals and professionals. Because it's not only a licensed person on the end of that phone. That could be somebody with extensive training on how to handle crisis calls. It's not just the neighbor Mary who answers the phone because she's at home. It's these folks get lots of hours of additional training on how to de-escalate somebody in a crisis state. So the intent behind 988 is to help spread the load, if you will, of the crisis calls coming in into the national hotline, and to make it much more easier for folks to access the services that are often difficult to get into. We've got 211 in the area as well, which is good, but it's more of a resource guide, not so much as a provider. With 988, it's much more of a provider intervention.
We know we just heard time and time again through the work of our study and our survey that people didn't know where to take the first step to get help. And so I love the fact that there's all of these conversations, and as Kirk was sharing, it's a complex problem to solve because there's a lot of different programs, both nationally, federally, at a state level, and even at a county level. But to know that there are such committed and dedicated people really showing up and having these conversations, and that there's a lot of work happening to bring more awareness, stigma busting, make sure that people know where to receive help when they're in crisis is really good to hear. So, as we know, suicide has been a hot topic and is one that has been really, really important to bring our attention to in the last 2 years. Suicide rates are going up. They're going up within some surprising populations. Women, for instance, professionals, youth. And one of the things that's really troubling is that about 28% of middle schoolers today have considered killing themselves in the state of Florida. So think about that. Almost 30% have considered ending their life because whatever they're dealing with, they do not feel equipped to in that moment. Also, in our very local data, most recent data that we did with our Polk County survey, we found that 1 in 4 respondents, so 1 in 4, had experienced 4 or more ACEs. ACEs means adverse childhood experiences. And really what that means is really bad stuff that you carry throughout your life that impacts your mood, your ability to be successful in life. But adverse childhood experience and trauma is treatable. Many of us in this room have committed our careers to giving individuals tools and help. One of those incredible fine individuals that has committed to caring for the heart and mind of our people in Polk County is Dr. Winny. And Dr. Winny, since the pandemic, we've seen all of this attention on increased mental health services and needs for children and adolescents. We're seeing an increase in crisis calls, Baycare Acts, things going on in the school. But it doesn't just mean that we need to increase inpatient beds and providers. We need to do those things. But we also need to be doing some things at home. Families need to be more aware. Can you speak a little bit on what you find the largest gaps right now for youth, their families, and those individuals in the community?
It's my pleasure. Thank you for asking that
Yes,
question.
and remember to scoot right up and talk right into the mic.
During this epidemic, we have seen an increase in depression, anxiety, stress, and suicide all around teenagers and children. National study says that we have about 30 to 35% increase in this phenomena. So all these children and teenagers who come to you have a lot of stress. You have to identify what the stress means to each different group. The child under the age of 7 may express it differently than a teenager. It may be different than a school-age child. So we have to identify what is the stress look like, the presentation of mental problem look like in these children. But as you said, psychiatric intervention is not giving medication or seeing a psychiatrist or Baycare acting. Because when the child come to me, they want to medicalize all the problem. But when a child come to me, there is a role for medication, but we have to look into psychosocial developmental model. We have to help them psychologically to cope up with the situation. We have to look into the family environment. We have to also look into the developmental aspect of it. So you have to have a good understanding of the psychosocial developmental model, and on the top of which we can look into medication. So psychiatric intervention is not answer for all children. Medication alone does not fix the problem. The combination of medical intervention, therapy, case management, and other community resources are needed for the best outcome. That will be my first sentence.
Okay.
Families need to have an understanding and have an expectation about certain behavior consistent with their age level. What is normal, what is not abnormal, or what is abnormal. For example, certain level anxiety is normal, but when the anxiety going too much, it is affecting their social life, academic life, and performance on a day-to-day life, then it became abnormal. That's the time to get the help. And being said, parenting skill taught to the new parents would be an early intervention, that many of these things is important, that you need to have the good fit with the parents and the child, the goodness of fit. So the parenting, teaching the parenting is very important, especially the new parents. And education to school, bus driveways, daycares, after-school program, etc., regarding the behavioral health awareness may be a good focus to start with, so they can identify, because many of them they don't know. For example, a child who may present with depression look like this: sad, mad, feel like nobody likes me, leave me alone. What's the purpose of my life? What's the meaning of my life thing? Poor attention, poor concentration, sleep disturbance, wish never to be born, wish to be dead. Okay? That is different. That is consistent for a few days to a week is a clinical depression. That is different from they have frustration and say that I am depressed, I am sad. You have to differentiate it. So when we look into that, we have to identify when to get treatment, when to refer treatment. Apart from the medication treatment, you need the psychosocial developmental model. You need to connect with the therapist. You need to address the parenting issues surrounding that, and we need to have the appropriate services available. Because the way I explained them, medication is to correct the chemical imbalance. But you have a skill deficiency. You have to learn how to deal with the frustration in a socially acceptable way. You have to know how to handle stresses at school. That medication is not going to teach you. You need to have the therapist work with you, but it takes time.
I love you speaking on this because it's so important to remember that we need more behavioral health resources in Polk County. That's apparent. We need more individuals who are physicians and therapists and social workers. But this isn't a conversation just for behavioral health professionals. It's also a conversation to be having around the dinner table at home, because there's a lot that goes into adolescence and youth and even young early childhood that's not just about the scientific and medication approaches to mental health, but it is about those coping techniques and strategies, awareness and understanding that it's okay and normal to have big mood swings. And often we find that what leads someone to suicide, regardless of their age, it's the loss of hope. And so we need to instill in our younger generations that there is hope. There's hope in coming to us as behavioral health professionals, but also that it's normal, it's okay, and it's human to have concerns like this. Now, when we speak to our kids, even my children and my neighbor's children, Dr. Winny, what are some of the things that we need our children to know and remember and understand about behavioral health today?
The common diseases I see in this community, as I said, is depression. And when the depression is severe, 1 out of 5 kids talk about suicide, talk about harming themselves. So that is where I have to look into whether I can treat on an outpatient basis or I have to Baycare Act. But also anxiety. Anxiety is a normal symptoms in certain level. But when the anxiety is increasing, it is affecting your school performance, affecting your day-to-day life, it becomes abnormal. Anxiety look like, anxious, nervous, worried, heart beating fast, difficulty in breathing, shaking, mind going blank, poor attention, poor concentration, feel like not going to school. Okay? It can turn into school phobia. Then you have separation anxiety. You want to follow mom. You want to be always with the mom. Does not want to be with the friends and shadow her all the time. And because you want to shadow the mom, does not want to have no social interaction. You can have social anxiety. But coming back again, there is treatment for it, medication-wise, but also needs therapy. Also have to work with the family. And then we talk about a lot of trauma in this area with PTSD. So having recurrent memories of the event that is coming as a flashback again and again and again, having upsetting and frightening dreams, worry about daytime, about the incident that happened again and again, that could be a clue that we are leading with the PTSD component. And many other patients come with ADHD symptoms. School is very aware of it, parents are aware of it. The symptoms of ADHD look like, for you to understand, it is like, poor attention, poor concentration, distractibility, impulsivity, hyperactivity, cannot finish the work you started, avoid, dislike, reluctant, things need sustained effort, on the move as if driven by a motor, forget to bring the homework they done yesterday. So that is how it look like. But we need to have the evaluation. But there are many other conditions can also mimic ADHD, such as anxiety, such as depression, such as PTSD, such as mood disorder, and other things. Then another issue that I always entertain is the attitude problem, which we call oppositional defiant disorder, which look like losing temper, argues with the people, refuse to follow mama's direction, annoying people, blame others for your mistakes, angry and resentful, spiteful and vindictive. Okay, so when it comes to that, we may say oppositional defiant disorder. So then there are sometimes I see a lot of kids with depression with psychotic symptoms. Psychotic symptoms include you can have hallucinations, delusion. You can have hallucination in 5 modalities. You hear voices which is not there, or seeing things which is not there. Feel like somebody is touching you, look around, there is nobody there. And getting smell like rubber burning and other things which is not there. Feel like somebody is watching in the night so they cannot sleep. That is psychotic symptom. That is hallucination. Hallucination is you can have in 5 modalities. The modalities include your hearing, seeing, smell, touch, and taste. Then they have delusions. Delusion means a firm, fixed belief that cannot be corrected by logic or argument. Okay, say that they are against me. Somebody is following me all the time. They got to look back all the time. Or referential thinking. They've gone to McDonald's or Burger King. People are talking about me. That is referential thinking. So paranoia, referential thinking, we see a lot. And many times we see a combination of all these things. So family history is very important. Psychosocial developmental history is very important. And then we have to know the details about how the treatment is decided. We have to assess, we have to understand the child, and we have to make the treatment custom fit for him. But one of the important things is not the medication alone. Medication has a role, but the child and the teenagers need other treatment like psychosocial developmental. Why I emphasize that is the one they don't want to. Many times they don't want to go to therapy, they want to come to the doctor again and again.
Fixed.
One more thing I will add to you is that lot of substance abuse has increased recently, especially after the COVID. Lot of vaping with marijuana is also noted. And we are seeing a lot of dual diagnosis because they already have depression. They're also using substance abuse to treat for it, or it is making it worse. Okay, then the substance abuse also contributing to problem. So what shall I do? It is very important for the parents to know when to seek help. How to get the parenting skills needed to help these children. and how to talk and communicate to the children about mental health, and how to recognize the signs and what are the protective things you can do. Okay, some protective factors that can decrease the risk of children include knowledge that their parents, certain things we can do is that talking to the children.
It sounds like that there's a lot of different ways that children can present today.
Yeah.
But is there ever a time that it's too early to reach out for help?
Yes. For example, when the things are affecting their social life, academic life, and you have to get the help. If the child is saying that I am depressed, and the child is not motivated to go back to school, their school performance is deteriorating, their hygiene is changing, and the patient is getting more angry, not able to pay attention or concentrate, and saying that I'm hearing voices, that is the time to get help. But each person and each age is little different how they present it.
Well, we want to encourage everybody, if you ever sense that there's something going on at home or with the child that you care for and love, never be afraid or worried about asking a question of somebody else, coming to someone in the behavioral health profession and saying, I'm worried about this. Maybe it's normal, maybe it's standard for that age or that developmental range, but we don't all get a manual on the day that we have children or when we reach adulthood about what's normal and what's typical. So we're here to help you through those moments. And I do want to point out that currently today in Polk County, we have 1,070 people per every provider. So Dr. Winny is one of those providers. The national benchmark for healthy communities is 270 people per provider. We have a lot of work to do. And I know many of our agencies are recruiting and actively adding providers, as Dr. Winny, but we're so grateful that he has been here with us in Polk County for 17 years and counting. We're going to keep you, Dr. Winny. Thank you for all the care you do for our patients today.
Thank you. For younger children, it could be marked fall in school performance, poor grades in school, severe worry and anxiety and afraid to go to school, frequent physical complaints, hyperactivity, persistent nightmares, persistent disobedience and aggression, frequent unexpressed temper tantrums, and treatment to or threaten to harm themselves. With adolescent and pre-adolescent, marked declines in school performance, inability to cope with the problems of daily activities, marked change in sleeping and eating habit, extreme difficulty in concentrating, depression, severe mood changes, strong worries and anxiety, and repeated school failures and fight, and drug use, threaten to self-harm and others, self-injury or self-destructive behavior, frequent outburst of anger and aggression, repeated threatening of running away from home. These are the warning signs that you have to call the mental health.
Very good. Thank you so much for sharing that information with us. For all of you, there will be a pop quiz, so I hope you've been taking notes. Now, Nicole, you currently today work at Lakeland Regional Health. I know that we have the privilege of working together every day, and Lakeland Regional Health is the largest Baycare Act receiving facility in Polk County. On average, we see 5,000 a year Baycare Acted individuals. And we have a lot of different services that we provide to those patients when they enter the emergency department and we're caring for them in crisis. Almost 90% of those individuals actually originate with law enforcement. So we are partners out there caring for the same individuals every day. And as we plan to add more services and more beds, we're not just excited about increasing our programs, but we're also excited about some of the really neat and special partnerships that we've developed within our programs. Can you tell us a little bit about the Peer Specialist Program and how that works today with Tri-County inside the LRH system?
Yes. So we partner with Tri-County to have peers come into our hospital to help our patients. At the beginning, we really didn't know what that was going to look like. We've read the research about how beneficial that program is, but we really didn't know what to expect. So we got our first peer.
And define for us, what is a peer? Because for some of us that are not in the behavioral health field, you may sound, ooh, that word sounds fun, but what is a behavioral health or mental health peer?
That's true. So a peer specialist in our world would be somebody who's lived the experience of substance abuse or addiction or mental health, has been through treatment successfully, is still going through treatment. They go through a certification program to be able to reach out to other people in need. So, and this is a statewide program that they can do. So when patients in crisis come to us and there's somebody that has substance abuse, mental health issues that maybe a social worker or a doctor maybe can't reach them at their level, the peers will go and talk with them about, what they've experienced, what barriers they had to overcome, some of the, issues they had to overcome and that they're still going through the program. So they can actually show them what success looks like. They can show them what sobriety looks like. And it really has connected some of the patients to, okay, I can do this too. And the peers continue to work with the patient even after discharge. So that is one of the big gaps, is not knowing where to go or what to do after discharge. And the peers can help them with that. They can get them into treatment. I feel like I'm on the phone all the time with Nelda or somebody at Tri-County, so it's really opened up our lines of communication too, just to make it easier for that patient to transition to the next level, whether it's a residential program or outpatient or just getting contact with a sponsor to go to AA, whatever the patient needs. It's really individualized. Just in February, the peers have helped over 100 patients. It's really amazing. And they help everybody in the hospital. So it's not only the mental health department, which is their biggest volume, but they help people on the medical floor that probably would have never even thought about receiving treatment. Because you could go in there for, chest pains or a broken leg, and you talk to your doctor, and then you say that something about a substance abuse issue or something else, and we can have one of our peers go and talk to them, and then all of a sudden now they're medically healthy, and they're also getting the treatment that they need for their substance abuse or mental health. So it is just an amazing program. I'm so glad that we were able to partner with Tri-County to do that. We have some of our peers here today, and they're just amazing individuals. They are like the definition of passion when it comes to this, because they're doing it. So just very, very thankful to work with them.
And can't you understand that as if you were an individual that were really having one of the hardest or most difficult days in your life, and you had a nurse come to you or a psychiatrist or a therapist give you advice, you're probably going to listen and take some notes and, try to do what they say. But if you have an individual approach you and say, hey, man, I was there, like I've been in your shoes, let me share with you a little about my journey, that works. Like that works all the time, every day. And especially when we work in tandem, when we work together. So we are really, really proud of our peers. We're so thankful for the partnership with Tri-County. Again, it's another testament to why when we do things together here in Polk County, it's even stronger and more impactful. Now, I know, Nicole, also in your role as a behavioral health manager, and you've had the term behavioral health on your badge for a long time. So a lot of people in the workplace often come to you when they're having concerns around an employee or a team member that have behavioral health concerns. And so I think that a lot of the people that are with us today, here in person and on the line at home or at work, are often, they're leaders, they're community advocates and volunteers. And when you aren't a behavioral health professional, but you have someone come to you in crisis, what are some things that you can share with those individuals so that they feel a little bit more equipped next time?
Sure. So I think the biggest thing is just making it okay for your employees and the people around you to be able to talk about it. You're not going to fix the problem or get them to help if you don't know that they have a problem or if they want help. So some of the things, definitely if your organization or company has an EAP, just make that available for your employees so they know there is an option for help. Some insurance companies, have list of providers that you can, access to. But the biggest thing is just knowing that they're able to come to you or come to maybe, someone at work to say that I'm having a problem, I'm having an issue, my family member's having an issue, and then that way you can connect them. Of course, if it's something that they come to you that is way beyond something you feel comfortable handling, reach out to the professionals, reach out to Lakeland Regional, Peace River, Tri-County. We can help with, connecting them to resources. We can help with some crisis intervention possibly. We can kind of guide you on what level that you might need, but it's the most important thing is to have an environment where they feel comfortable coming to you and talking about it. That's how you get people help, when they know they can come to you and ask for it.
Absolutely. Mental health is treatable. We all have concerns throughout our life. And currently now today, we know that 1 in 5 individuals in the last year is going to have, or in the year ahead, 1 in 5 are going to have some concern that they really would benefit from mental health care or treatment. I mean, just look around at us. How many people today are on our panel and in our community room here today? That's a lot of individuals that need help. And so you're going to interact with those people at the dry cleaners, at work, in your soccer games, and in your community, your faith-based organizations. So being willing to ask, are you doing okay? And really hear an honest answer, staying with them till they get to safety is important. Now, Nicole, we've already had a question from the audience, and I felt like it was really pertinent, so I'd go ahead and ask it to you now. How long must a peer be sober or have no offenses before qualifying to become a peer specialist at Tri-County or Lakeland Regional Health?
Okay, I might need some help from my peers, but I think it's 2 years, is that correct? 2 years.
Okay,
Yep.
so 2 years, that's a very good question. So peers, to go through the state certification program, they must be sober and in treatment and not have any legal offenses in a 2-year period. So I know we would gladly get anybody more information. We really have some really wonderful, passionate people here, and we're always looking for peers in our community. All right, Miss Nelda, we've got some good questions for you here. Now, I know, and Dr. Winny had used the term dual diagnosis or co-occurring diagnosis before, and I thought you would be a wonderful person to really shed light and kind of define for us what is dual diagnosis or co-occurring diagnosis. And then I want you to go further and just share a little bit about, in the many wonderful years you have been in this field, how have you seen treatment approaches change for that condition? And remember to talk right into your mic so our folks can hear.
That is such a big topic. When I first started considering, dual diagnosis, the first time I heard that word was around 1980, I believe, and quite honestly, it surfaced in talking about individuals who had substance use disorders and mental health issues. And that's what they were referred to as a dually diagnosed individual. And so as I started thinking about this question, I thought, how do I explain the difference? Because now I think that it spans and has moved over into the full medical field where there's differences. I do believe that the terms are used interrelated. I think that you can use dual diagnosis, and any professional who knows the term is going to understand it. You can use co-occurring, and they're going to understand it. I believe that with dual diagnosis, what you can consider is it can refer to any combination of 2 physical conditions occurring in a person at the same time. It also can occur, it's often used, like I said, to refer to substance use and mental health disorders, whereas co-occurring more specifically links what is going on with the person. In other words, the individual may have developed a mental health issue because of their substance use, because of organicity or the changes in the brain, then the mental health issue developed, or vice versa. The individual could have mental health issues, not go to a psychiatrist, not get medication, so they start self-medicating with substances. Because I go back many, many years, some of the things that I have seen that through the changes, originally I came into Tri-County into an adolescent facility. And what we saw with the adolescents at that time, they were being treated for their ADHD, as Dr. Winny talked about. They were being treated with Rohypnol. But guess what they did with it? It became roofies, and it became date rape drugs, and at the same time they were using their marijuana, they were using those kinds of things. That went out of the picture, and you had more sophisticated drugs like GHB and MDMA, which is still out there and being used currently. In 1995, Tri-County came to me and said, look, we have an epidemic, and it is with crack users. And we have this problem with pregnant and postpartum women, and we want to establish a residential, actually at that point in time, the RASU initially meant the Residential Assessment and Stabilization Unit for Women. And initially, all we treated were pregnant and postpartum women. And that was a result of crack being so prevalent and the research that was coming out of these individuals who were having babies born addicted to crack and having to be detoxed from that. At that same time, we were seeing some black tar heroin. Not a whole lot, but there was some. And so there was a lot of concentration, though, put towards the treating the pregnant and postpartum. From that, though, we grew into a more treatment-oriented facility. So,
and why don't you tell us a little bit about what is a Marchman Act?
What is a Marchman Act? A Marchman Act it's a civil proceeding that, once again, law enforcement and the sheriff's office gets involved with. An individual who is using substances, if their life is out of control, and they have people who are really concerned for them, they can go to the courthouse and they can fill out papers. A doctor, several different types of professionals can also do it. And these individuals are then ordered to go to our detox facility, where it depends on the condition they're in when they come to us. They can stay up to 5 days, but during that period of time, they will receive a screening. And in that screening, it will be determined, is this the first time this person has come into the system at all? If so, by law, it says what we have to do is give them an opportunity to participate in the least restrictive setting. So many times they will be referred to outpatient. But the court system follows them. It is a court order. And if they have received treatment and they need residential treatment, then we set them up with that. If they need outpatient treatment, it is a way. With a mental health diagnosis, the individual will be Baycare acted for 72 hours. With a Marchman Act, that Marchman Act now can last for up to 90 days, depending on what the court orders, and depending on the severity of the issue that we're looking at.
Well, thank you so much for breaking that down a little bit. And I know, because it can be confusing. You hear these terms in the news and in kind of just like sort of conversations, and it sounds scary, but really, to boil it down, both a Baycare Act and a Marchman Act, it's a way to get somebody help before they feel ready. And there's not a lot of penalty around it in that, but it allows us as individuals to really help intercede and start that journey for someone. They have a long way on that journey of recovery to go that they will then have to pick up, but it helps us get that immediate care to them. Now, Nelda, in our data actually from the study from Polk Vision, we found that these were the following most kind of underserved communities right now identified at higher risk here in Polk County. People experiencing homelessness, at-risk youth, first responders, individuals of lower socioeconomic status, senior citizens, migrant and agricultural families, people of color, and people who identify as LGBTQ, and incarcerated citizens. There are a lot of different individuals that need our help. And I know Tri-County does a lot of services amongst these populations. You are really known for that. And you even care for youth, correct, in some ways? Share with us a little bit about maybe a few of your programs that you offer, if you will, in Tri-County's rich array of services that may target some of these groups.
Okay. One of the things that Tri-County does is we serve Polk, Highlands, and Hardy County. In Highlands County, we have prevention who actually go into our schools. We used a program called Strengthening Families. It is an evidence-based practice where literally they may come together and prepare a meal, and it is the individuals who participate in this program are identified at-risk children and families in the school system, and it acts as a support system for these individuals. Our prevention also may, depending on what it is the school is experiencing, they may go in and talk about bullying, or if there is a lot of nicotine use or marijuana use that's cropping up. Right now, a big thing is vaping. Everyone wants to vape, and so they may go in and just educate what we know about those kinds of services at this time.
Wow. That's wonderful. We know that there's a lot of work to be done, not just on helping those people in crisis, but helping prevent crisis. And that starts with education, awareness, curriculums within the schools, teaching for our parents and new parents, and particularly, there's a lot to be done.
The other thing that we have, Nicole, for our adolescents, we do have outpatient services where the adolescents can come, and we can link them then with psychiatric services if they need it. We have that in Highlands County, and we also have it here in Polk County.
That's wonderful. And thank you so much again for your personal work and dedication to the OB and perinatal population. That's something that's very important to all of us. So truly a testament to your commitment. Now, we've started getting some questions from the audience, which I love, so please bring them, and continue to text in. And for those of us that are here live, make sure that you're using the text box, and for those of you that are at home. And the first question that I thought was a really good one is an overarching question. As Polk County continues to grow, are we capable of handling the potential increased caseload of behavioral health? That's a really big question. And I think the optimistic answer is yes, but not today until we still have some more work to do. So the easy answer is we need more beds, we need more clinic appointments, and we need more providers. But the other thing that I really want to call your attention to is it's also not just about adding more, which we definitely need that. It's also about the strategy and the tactics and the strategic plan that we do to make all of those pieces move together. That's one of the reasons why I'm really, really proud of the work of Polk Vision. It's about doing more of what we're doing today. It's about all sitting and acting on the same team when we address these problems of mental health. We will be able to continue to meet at a better and increasing level the needs of our community if we work smarter, not harder. If we continue to add not just providers, but also programs and ways for them to work together, the ways for public safety, the business fields, private, not-for-profit, all those various corporate entities all coming together, we're going to be better. So I'm optimistic, but we have a lot of work to do. Now, Dr. Winny, we got a question for you. Okay. All right, so remember to get right close up to the mic. How do you diagnose a substance use disorder with marijuana when it's become so popular and in many states even legal, especially when an adolescent doesn't believe that there's an issue? How do you view that as a provider?
It's an interesting question because they want to teach me, say that that's the answer. Using substance is the answer. No, but I have to bring them to the evidence what APA is saying, what the American Academy of Child and Adolescent Psychiatry has to say about this is not the treatment approved for depression or for anxiety or for ADHD, none of these things. So I will quote them. So this is the study we have looked into, and this is what we have found. There is no clinical evidence. There is no evidence at this point in time this is going to work. But you want to convince me that this is going to work. Okay? But why you started taking the medication? Then I have to look into the comorbidity part of it.
Sure.
Then I will identify that there is a depression, or there is a mood component, or there is a trauma involved, there is a family history of mental disorder. Let us look into each one of it. Then I have to tease out what I can treat, at this point in time with the medication, where I have to refer him for the treatment. And if I see a substance abuse or dual diagnosis, then I have to get the help of Tri-County. So, but the point is that you have multiple problems, you have to address the multiple problems also.
Right.
So it may not be one, because I may start here, I may refer them, but I will continue the medication management and send to Tri-County. That's how I go. But most of the teenagers want to say that this is the answer. And sometimes they come to me and say that you prescribe medical marijuana. I don't believe in that at this point in time because I don't have the evidence at this point in time.
Right.
But there are some other doctors do it. You can always go to the doctor. Until I am convinced that this is clinically appropriate and there are clinical evidence and there are scientific evidence, there are research to support me, then I will talk about it, then we can discuss about it.
And it sounds like, I think that the most meaningful kind of recovery from any type of mental health condition or concern, it's not just one thing. If you only use one thing, then you're missing out on a lot of the really important coping tools, the resilience things that we need to learn as a young person or as an adult, wherever we are in our journey in life. If we use one thing to kind of make it all away, we're really missing a lot of the opportunities. Now, another really good question, I think several of you might actually be able to share on, but Kirk, I'm going to start with you. How do we follow up with people if they're homeless after a Baycare Act or get them into treatment resources?
That is a good question. All right. So it is a challenge because they're homeless and sometimes they're transient. But one of the things we're doing with our expansion program is we've partnered with the officer or deputy who's involved with the homeless camps. And we go out with them to the camps and we're finding people and going, hey, I remember you. Let's talk. And so that's how we're kind of starting to approach it. And that's a fairly new thing within the last 6 months or so, where we're partnering with law enforcement, going out to those camps. They have a different need for going out to the camps, but we've built that relationship with that individual so that we can go out and they understand what we're there to do, they understand what law enforcement's there to do. So we're trying to reach out to many of them. Some we just can't find.
Right.
And it is a tight-knit community, the homeless community. They do watch out for each other, and they know a little bit about each other. And oh yeah, Bob, yeah, he's the one that with that little tent over there in the corner. I haven't seen him in a while, and they're concerned about each other, and they watch out for each other, which is great because it helps us kind of find them. And sometimes we'll hear, yeah, Bob moved on. He's in Winter Haven now. He's not in Lakeland anymore. He didn't like it here. So we're able to kind of track a little bit that way. But it is no easy task. It is a challenge because the affordability of medications, getting them to their appointments, especially with a transient group, we can do all the wonderful things and line up a good aftercare plan for somebody. But if they don't come, it doesn't work.
Nicole, talk with us a little about how, like on the hospital side, so, Lakeland Regional is after law enforcement has brought them or mobile crisis has intervened on the front end. How do we as clinicians and social workers and therapists try to set up the most successful plan as possible for someone that doesn't have a permanent residence?
Definitely. So once the patient is stable and able to start working on their realistic discharge plan, we provide them with all the resources that we can about homeless support, housing, and just being realistic with them. Like there could be a waiting list. You need to do this right now. Use the phone here in the hospital before you leave. Call. And once again, to plug the peers there, of course they can call them once they leave too. Because maybe they're just rushing to get out of the hospital because they're anxious or nervous about being in the hospital. We give them resources they can call. They can call us back. They can call the peers. We do make them an appointment within 7 days for an outpatient provider. So if they, choose to use that, they could follow up with Peace River Tri-County and talk to somebody there about the housing options. So we definitely provide them with all the realistic resources and also give them a number that they can call if they have any questions.
Very good. All right, Dr. Winny, I have a good question for you. How are we, and I can't wait to hear your answer because I need to know this, how are we going to draw more professionals to this area in the field of behavioral health? Remember to sit up and talk right in your mic.
That's a very nice question. I have been the child psychiatrist here for 17 years. I have difficulty in attracting people to come here. So the point is that I keep a lot of connection and lot of relations with many of my colleagues from different area and different places, was also heading residency program. So they know me personally, so I will communicate them. Second thing I do is that when I go to every meeting, I try to be with the younger colleagues and talk to them. They come to me. Sometimes they transfer their CV to me. So the point is that I talk about Florida, and the good news is that we are seeing more people interested in Florida. And I am getting calls at this point in time from California, from New York, from Chicago. There is a move towards California at this point in time.
Okay.
But the point is, that is a good news. I have never seen this kind of move. So yeah, they may come, may not come, but the interesting thing is that they are also calling. Second thing is that another issue with Florida versus other places was there was a discrepancy in the rewards they were getting and they were working in the state financially speaking compared to other places. But the point is that gap has been removed at this point in time. So we are following a nationalized kind of a, evidence-based kind of what the benefit is at this point in time, like Sullivan and Cutter or MGMA ratio, that helps us. Third thing is that the population is moving towards here.
Okay.
So there are a lot of people who are interested in mental health who want to join here. The fourth one is that there are in Florida itself, we have a lot of places is opening up a residency for psychiatry because of the specific need. One example is Lakeland Regional Medical Center. You are going to have the residency program starting with the 4 new residents because if you are in Florida, if you are in Polk County, they have an attachment to the Polk County. They have a relation to the people who teaches them. Okay, so they may stay here. And we, Baycare system, has identified it. We have a residency program in psychiatry in the other side of Baycare, that is in Tampa. We are in 2022 starting with 6 residents in psychiatry, which will be increased to 8 residents next year. Great. And we want to grow because we want to attract the same problem. We don't have enough psychiatrists. So I may be also a teacher. So the point is that you need to have a relationship with the people. And it is a relationship that holds you back into this community. With the same question in mind, you know that at the Sweet Center where I am, at the CBH, that half of our place is occupied by the residency program, family health residency program. So they rotate with me in the psychiatric rotation at this point in time. So the whole idea is that the more residency open up in this area, so they maybe tend to stay more in this area. I've talked about a few cases in Polk County, but that is happening in Tampa, that is happening in other places also. So that is what I can do. But mental health need is increasing and increasing and increasing.
We do.
Another statistics is that the most liked residency in America at this point in time among medical students is psychiatry.
Psychiatry. We need psychiatrists. We need people to do residencies. One thing that's really cool Polk County has going for it is that we actually are considered a rural health area. So when you're looking at federal repayment loans for often, because medical education is quite expensive and lengthy. And so sometimes even if someone may even live in the Hillsborough County, or Orange County area, they are motivated to come and work in Polk County because it's often helpful for them repaying loans. But what we know is that if they fall in love with us, like Dr. Winny, maybe that they will stay. And I will say, as Dr. Winny shared, Lakeland Regional Health is moving into the general medical education. We're really excited to be launching our own psychiatry residency program and building a new building because we hope that if we build it, they will come. But it's not just about any one provider being successful. It's about all of us being successful. We have a lot of work to do in that number of how many providers we have per individual that lives here in Polk County. All right, Nelda, this is a great question. It's a big question, but if someone wants to get help, how do they know where to go or who to call?
That is a big question, but what I can tell you is there is no wrong door. So it doesn't matter where you start. I think that if we're talking about Tri-County and you're wanting to get services, you can call administration, you can call the top number, and they're going to give you they're going to put you in touch with someone who can get you where you need to go. If someone, just last week, someone came in and literally they were someone who had spent the night on the street, and before noon, I had actually taken the company car and I had taken that individual because this individual told me that she was hungry, she needed this, she needed that, and obviously she had been using, so we got her put where she needed to be, which was obviously the detox facility. So start asking questions, call places, get in touch with any one of the facilities associated with Tri-County, and they will get you where you need to go.
I also will share that just by registering and being a participant here today at our presentation and our conversation, you will be receiving a pamphlet or a QR code that provides some local resources that is really, really good for you. And again, even if your daily work and life isn't in a behavioral health setting, you now are already armed with some really important information. We know that medication or all the years of school that we do to do treatment interventions isn't what prevents suicide. It's not what gets people together. The number one thing that we can do to prevent suicide, it's community. It's us coming together. The National Institute of Health and the CDC has shown that over and over again. It's that when we ask somebody, do you need help? Are you okay? It's them being brave enough to be honest. And it's us being willing to listen and hear that, to slow down and really listen to the answer. And 9 times out of 10, you're probably like, I have no idea what to say. I have no idea what to do. But just knowing that I'm going to hold on to them until I can get them to the next step. That counts for if you are a manager or a supervisor or just a peer or someone that runs into somebody, like I said, at church or on the Little League field. Just knowing that you can get that person to one of us, one of our team members, someone at an emergency department, a primary care clinic, getting to an expert. And then really, if you ask that question, listen, help patch them together with a professional, follow up with them. Let them know that you're proud that they asked for help. Let them know that they were brave and that you were grateful that they gave that response. Because one day, it's going to be you that needs help. Or one day, it's going to be your child or your spouse. We never know who, when, or where. And if all of us are willing to do that, we have already created a network that is safer, healthy, and more nurturing and growing for behavioral health concerns. Now, we've talked a little bit about stigma, Kirk, but can you share with us what are some other ways and things that we should be thinking on things that we can do to reduce the stigma associated with mental health issues?
All right, so this is a big one for me. It's because, and I mentioned it when I talked earlier. When I start off talking and training law enforcement and others in the area of mental illness, I asked them to share with me the terms we use for individuals with a mental illness. And the list is huge. Some very derogatory. I mean, I'm like, no bars hold. I mean, just come on, tell me what you got. You're not going to offend me any way, shape, or form. And we get this huge list. And it varies. I mean, I'm not going to share some of the terms here. And then I ask them, okay, and I just change my marker and I go, okay, so what do we call people with heart disease? And there's, whoops, you could feel the brakes come on. Okay, what do we call people with diabetes? What do we call people with cancer? And they get the message. The terms we use for individuals who have an illness, such as mental illness, is pretty important. And I said early on that, this is the type of illness where we push people away when we really should be embracing them and coming closer to them. A lot of the issues that they present with and come at us with makes it a little bit prickly. I get it. Okay, it's hard to hug a cactus, but we love a cactus every once in a while, don't we? All right, but we've got to pull folks closer. They are survivors. They are struggling. They're brave and have courage. Just think about any of us walking into a mental health provider. It takes a lot of courage to do that, to say, I have an issue. And often that is seen as a weakness. And quite honestly, that's bravery, that's courage. To say, I'm not so well. So we've got to be able to open ourselves up to look at folks with these kinds of ailments and say, we're here together, I'm here for you. And we talk about, being present. That's really what it's about. We can have the alphabet soup after our name, and we've got all the tools and the tricks and all that fun. Yeah, great. It's presence. And it goes such a long way that we as a community can come together and build a really strong mental health community. Not only is it good for our mental health, it's good for our physical health as well. And this is nothing new. This concept is nothing new. Let me introduce you to a gentleman by the name of Emile Durkheim. If you've not ever heard of Emile Durkheim was one of the forerunners for the study of sociology, and one of the things he did was study the issue of suicide. And of course, wonderful tome, it's about yay big. You can read the study. Just be cautious, the title of the book is Suicide in big letters. So if you're walking around with that book, it's going to raise some questions. But it starts a dialogue. But what he found, many things with regard to the issue of suicide, because it's always felt that that's a private issue. It's a societal issue. It affects all of us. And what he found out, and that was written over a century ago, many of those findings are still holding true today. One of the big ones is our social connectedness. And what we know is that people in social isolation tend not to do as well, and that they have higher rates of suicidality. So what Emile Durkheim was pointing out is that, look, if we come together as a community, we can build those protective factors, be there for one another, because we're all struggling, we're all humans. This is the human condition, we're on the ride together, woo-hoo, right? And some of us, it's a little bit bumpier for us than others, but we can be there together. That was a big thing through COVID. We're all in it together. And it's like, well, yeah, you got a nicer house. I don't, you got it a little bit better. But, it is something where we're all struggling with emotionally. And really, we need to be embracing one another and embracing folks through this whole process.
Thank you so much, Kirk, for that. There's a lot we can do. And I know I'm feeling good because this is a really hard topic. It can be a really prickly topic at times, but you guys showed up today and you gave some of your time and of your busy schedule to learn a little bit more and move forward with some of the concepts around behavioral health. I hope that you've learned a little bit about some of the amazing work that's already happening today around the county, but also I hope you're ready to roll up your sleeves and go out there and talk about mental health to help us break down this stigma, break down these silos. Now, our time together is drawing to a close. We found this discussion so informative and helpful. Thank you so much to our panelists. I mean, just really remarkable. Grady Judd had to step away to handle some important county business, but again, we're so very thankful for his time. We'd like to thank PGTV for being here and making it possible to record this and share this with others who couldn't be with us in person. We really want to, again, thank the city of Winter Haven for hosting this event. This is just a gorgeous location and wonderful venue. And a sincere thank you to Polk Vision and their staff. Kim Long, she's just a remarkable individual and leader. We're so thankful for her. And Ashley Surgeon, Tara Watson, John Michael Wampler, we're so very thankful. And we also want to give a sincere thank you to our leadership Polk Alumni Association and the Polk Vision Behavioral Health Team for having this be possible. And I wonder if MJ Carnival would like to step up for a few minutes as our chairperson for the Alumni Association. Thank you so much, MJ.
Good afternoon, everybody. It's hard to follow Alice's energy, but thank you, everybody, for coming today and just showing up. On behalf of the Alumni Association, it's greatly appreciated, and it's good to see everybody here learning about this topic that just has far-reaching impacts. And thank you to the panelists for providing your time and sharing your expertise with us. I just wanted to remind all the alumni in the room that we have our Tigertown event coming up in early summer. So keep an eye out for that. We will have some time at the baseball field there, and that'll be a little bit more of a social event, but we're looking forward to seeing everybody. Thank you, Alice.
Absolutely. So another quick reminder I just wanted to share with you in closing that in recognition of Mental Health Awareness Month, Peace River Center, in partnership with Polk Vision and other local mental health experts, they're offering a series of free mental health panel discussions during May. So remember, this is not an end here. This is just the beginning of so many other remarkable and really important conversations to be had. Plans are underway. There'll be lots of helpful information covering topics such as trauma, youth mental health in the workplace, some of the things that really came about today. And so stay tuned to both Peace River and Polk Vision's social media channels for website and details. And to you, thank you again for sharing the vision, and thank you from me personally for allowing me to be here. It's a really exciting time in my career because I'm getting to roll up my sleeves and wear a hard hat and help really build something at Lakeland Regional Health. We are building an 80,000 square foot building. We are bringing a lot of new programs and providers to this area. We have a wonderful, growing, robust team, a lot of programs that are all going to be centered on helping meet the need of people that live in this community, in our backyards and in our neighborhoods. But with all that going on, I'm almost as or more proud of the incredible work of Polk Vision, the behavioral health team, because really it is about breaking down silos and doing this together. This is the right time, this is the right place to make an impact, because we are in fact aligned. We are getting in the same room and having really hard conversations about these topics. So continue to help me remember that you have importance and value to the topic of mental health, and I look forward to hearing and seeing all of your wonderful faces again in the future. Have a great day. Thank you again for being here and participating today.